All right, why don't we get started? I would love to welcome everyone to the Society of Skeletal Radiology Resident Education Club webinar. My name is Bill Morrison, and I'll be serving as moderator for this session. Reminder, everybody sign in to Poll Everywhere so you can participate in the conference. It should be in an email that was sent to you, or it's in the chat, the link for it. It is my distinct pleasure to introduce a rising superstar in musculoskeletal radiology, Alessandra Sax, who is Assistant Professor of Diagnostic Imaging at Alpert Medical School of Brown University and Rhode Island Hospital. And she'll be talking about musculoskeletal infections. Ali?
Hi, thank you so much for the introduction, Dr. Morrison. And thank you to the SSR for inviting me here to give this talk today. The focus is, as you guys have been made aware, is musculoskeletal infections. This is just a brief overview slide of the range of musculoskeletal infections that we are going to talk about, starting from the more mild infections such as cellulitis to the more severe infections such as necrotizing fasciitis. Now, before I begin, I just want to give a shout out to this excellent crew of musculoskeletal radiologists who put together this paper for us, describing the different imaging appearances and how we talk about musculoskeletal infections. So here's just that screenshot of that article. If you want to save it, bookmark it, it's super helpful. This is our first case. This is actually a 26-year-old male who has a history of immunosuppression. He first just got a radiograph in the ER for severe right-sided hip pain, loss of range of motion, and before any labs were obtained, it just showed just some joint space narrowing, which is more than you would expect in someone who's just 26 years old. And then he actually went to get an MRI, and it demonstrated these findings here, which shows a large joint effusion surrounding edema. There's debris in this effusion, and there's some hyperemia of the femoral head and acetabulum. So what do you guys think we should do first for this case? Good. Can give it a couple more seconds, but it looks like people are leaning towards tapping the joint or aspirating the joint, which is the correct answer. Next question is place your needle, place your arrow where you think is the best place to aspirate this joint. You guys are good. Exactly. We tend to aim for the lateral femoral head neck junction. I won't go into too much depth because I know there's a talk coming down the line on joint aspirations. But the reason we aim for the lateral femoral head neck junction is because of these babies here. You remember navel from, boards or anatomy, nerve, artery, vein. So we try to avoid these structures here. And then hopefully by going lateral, you'll also anchor yourself nicely in one of the muscles. So sartorius here, rectus femoris here, and iliopsoas here. So this arrow is just pointing where the aspiration needle track should be through rectus femoris onto the lateral femoral head neck junction. So here was an attempted access into the joint. Where do you think this needle is, guys? Take a couple seconds, look at these, and then I'll switch to the pull everywhere slide just because the picture gets a little smaller on that pull everywhere slide. Yeah. Exactly. So it sounds like we're leaning towards it is not in the joint. And that is correct. This was actually not done by a radiologist. It was done by a PA. So they didn't recognize that they were extra articular and actually went to MRI or because it could have been done by a fellow. We all miss joints. It happens to the best of us. But you should be able to recognize on your arthrogram when you're not in a joint. You should see that nice collar of contrast around the femoral neck, perpendicular to the femoral neck. So here is the MRI. And we're not seeing any fluid within this joint, and it's all here. So now where do you think the needle was? Good. People are leaning towards iliopsoas, correct. I tried to prime you guys with a little quick anatomy slide, not that you guys wouldn't know ahead of time without that priming, but yeah, it's in the iliopsoas. So this guy was actually, after they aspirated the joint, they found that it was infected, and he had a washout, and actually came back a month later with this radiograph, where we can see now that that joint is now almost completely effaced. We've got erosions at the femoral head, erosions at the acetabulum. And he also went on to get MRI again. So here is our T1. And then here is this is actually a post contrast. And you can see there's this is thick synovium, lots of edema at the femoral head, marrow replacement, and some areas of enhancement and non-enhancement along the intertrochanteric region and femoral neck. And diaphysis. I'm just going to leave these images here for a little bit, just so you can take a longer look at them, and then move on to our poll everywhere slide. All right. Which of the following is not present? Looks like people are leaning towards C, D, and E. Most people at C. The answer is actually abscess. So we can see here that we've got this intense edema spanning the hip joint or femoroacetabular joint. And the edema here is enough to call a fracture. We actually do have a little bit of linear T1 signal also on the T1, but just the degree of this edema here is intense enough for a fracture. And then, yeah, there's definitely osteomyelitis, right? There's edema, there's marrow replacement, there's septic arthritis. That joint is distended, the synovium is thick, there's debris in there. And then you can see on the post-contrast enhanced images that there's actually areas of enhancement and non-enhancement within that area within the intertrochanteric region. So that's where we actually have the bone infarct. Ooh, why isn't it going for? There we go. This isn't a poll everywhere question, but this was actually treated with, because of the bone infarcts and the fracture, it was treated with a hip replacement. And if you just notice, the acetabular component of this hip replacement is probably double the thickness of what a normal hip replacement acetabular component is. This is actually an antibiotic impregnated acetabular component to this prosthesis. So if you guys hadn't figured it out already, that first case was of septic arthritis. So this is a joint infection. It's usually monoarticular and presents with erythema, warmth, swelling, pain, and loss of range of motion. This extreme pain and loss of range of motion is why our patient came in. And then they have other systemic signs of infection with fevers, elevated ESRs, and CRP. This most commonly spreads hematogenously, but can definitely spread contiguously or from direct inoculation from either trauma or infected hardware. And then staph is the most common culprit for septic arthritis. So our imaging hallmarks are going to be this joint effusion with synovial and capsular enhancement and a lot of adjacent inflammation. And I think it's just important to emphasize that this degree of synovitis and inflammation is out of proportion to what you're seeing interarticularly. I mean, we see septic arthritis, in patients who have rotator cuff tears and osteoarthritis and meniscus tears, but that degree of inflammation has got to be out of proportion to what you're seeing interarticularly. And then there are other imaging features such as osteopenia. We actually saw that in our case on the radiographs. You could see this periarticular osteopenia. And then when we get to the more advanced imaging, CT and MRI, subchondral edema, synovitis, erosions, and osteomyelitis. And as you guys appropriately said, this is diagnosed with an urgent joint aspiration. So a native septic joint is one of our orthopedic emergencies. It takes just 24 hours for the cartilage to start getting destroyed. So this is something that usually just requires a call just to make sure that the orthopedic surgeon, or at least the emergency physician, who can then relate to the orthopedic physician, that this needs to be aspirated. And this usually really only gets imaged because they're ruling out other causes of joint pain, and the clinical suspicion for septic arthritis was kind of lower on their differential. This is one of our septic arthritis mimics. So what we can see here is a joint effusion. We've got a thick rind of synovium, and then all of these small, pretty uniform interarticular bodies. We tend to call those rice bodies. This is a case of rheumatoid arthritis. For our next question is going to be, what arthritis typically also has rice bodies? Good. Looks like we're leaning towards tuberculous arthritis, and that is correct. This is another arthritis. I don't know if this radiograph is coming across well, but we can see that there's calcification here within the medial joint compartment. We can see some of those calcifications here on the MRI. And we can also see that this synovium is a little thick and is demonstrating some enhancement. This happens to be a case of CPPD. And then here's another case. We can see that there is a joint effusion, but there's also this marrow replacement here along the posterior lateral femoral condyle, and then a ton of edema adjacent to this marrow replacing lesion. This happened to be a lung metastasis. Some other septic arthritis mimics is going to be your rapidly progressing idiopathic arthritis. So this is going to be an arthritis that occurs over the span of a year, resulting in either half the total joint space loss or greater than 2 millimeters, and then joint collapse. This is differentiated from the septic arthritis because the tap is usually dry, whereas in rheumatoid, you often get a tap and it's got a lot of inflammatory markers, white cells, neutrophils, that can mimic infection as well as systemic signs of infection. And then in CPPD, usually those elevated inflammatory markers systemically aren't as high as they are in rheumatoid and in septic arthritis. And when you tap that, you're still going to get some inflammatory cells, not as high as in rheumatoid or in septic arthritis, but you're also going to find crystals. And that's what we use to diagnose the septic arthritis, is actually those inflammatory markers, because it's such a rapidly progressing process. Waiting for bacteria to grow takes too long. So you tap it, see if there's enough inflammatory markers, and then they can either get washed out or not, depending on what they find. This is actually a case I stole from the SSR white paper on musculoskeletal infections. And we can see that there's like a ton of muscular edema, fascial edema and fluid pockets within this thigh musculature. And our question for this is going to be, what is the most urgent diagnosis for these images? Looks like we're leaning towards A, our necrotizing fasciitis, and that's correct. This is just another case of necrotizing fasciitis, thick, very marked fascial thickening, fascial edema, and also some adjacent soft tissue infection. And then here is one that you guys, I think, are more accustomed to seeing, especially for board questions and board studying, is all of this subcutaneous, intramuscular, interfascial air. But it's important to recognize that air is not necessary to diagnose necrotizing infection. Our criteria actually has to do with the degree of fascial thickening. And in fact, air isn't seen in 50% of the cases of necrotizing fasciitis. And this is important to recognize because it's an aggressive, rapidly spreading infection along the muscular fascia. And it's caused by toxin and gas producing bacteria, which causes tissue necrosis and vascular thrombosis. And because of this tissue necrosis and vascular thrombosis, it impedes the penetration of antibiotics. So this is managed with emergent surgical debridement. These tend to only get imaged, which is why I had to steal it from the SSR white paper in uncertain cases. I didn't actually have any good examples at Brown. But imaging should never delay the treatment. This is a clinical diagnosis. We just kind of stumble upon it when the clinical scenario is uncertain and patients get imaged. And then some risk factors are going to be diabetes and immunosuppression. So our imaging features is going to have to do with this intense soft tissue edema, intramuscular edema, fascial thickening, and all of these fascial fluid pockets and abscesses, and these all enhance. And then, as I had said previously, gas is not always present and is in fact seen only in less than 50% of the cases. There are some mimics for necrotizing infection, such as going to be cellulitis with abscess and air. So that air is going to look like it's going to be necrotizing. And then direct inoculation of air from trauma, recent surgery. Maybe patient had a recent laparoscopy and the air got out into the soft tissues of the abdominal wall. And then this example here is actually just non-necrotizing soft tissue infection where we see just some muscular edema. The fascia are just a little bit thickened and enhanced just a little bit. It's the 4 millimeter thick fascia is how we diagnose necrotizing fasciitis. All right, I'm going to give you guys a moment to take a look at these images. These happen to be of I think he was a 47-year-old man who had picked out a blister on his finger and then just came in with a lot of swelling and pain. All right. Which of the following are present? Good, it looks like we're leaning towards all of the above, and that would be correct. So we can see here that there is fluid surrounding the flexor tendon sheath. There is edema and enhancement spanning that interphalangeal joint of that finger. There's surrounding soft tissue edema and enhancement. So this is a case of septic tenosynovitis, cellulitis, septic arthritis, and osteomyelitis. They got the full works just by picking a little blister on his finger. So septic tenosynovitis is another one of our musculoskeletal emergencies. So this is an infection within a tendon sheath. And this is going to be evidenced by complex fluid within that tendon sheath. And just like we saw with the septic arthritis, that there's going to be a lot of enhancement surrounding that tendon sheath and surrounding hyperemia, which again is out of proportion to what you would expect just for a post-traumatic or overuse tenosynovitis. And this is also managed with emergent debridement. Risk factors here are trauma, as in our case, surgery, and then IV drug use. I guess those could all be considered trauma, but this is just another example of septic tenosynovitis within the posterior tibial tendon sheath. And you're going to see that, like, all of these flexor tendons have some tenosynovitis, but the posterior tibial tendon has this marked surrounding hyperemia and enhancement out of proportion to the degree of fluid within that tendon sheath. And this is a similar case to what we had seen in the finger. Marked distension of the extensor hallucis, also with this joint effusion, which is actually eroding into the metatarsal head here. So another case of septic arthritis, septic tenosynovitis, and osteomyelitis. This is one of our septic tenosynovitis mimics in a wrist. You can see that there is distension of this fluid tendon sheath, and there is some surrounding soft tissue edema, but the enhancement is relatively smooth, and there's not a whole lot of surrounding soft tissue enhancement. And this happens to be a case of rheumatoid arthritis. Right. You can put more than one answer in here, so you can name all three if you'd like for our 3 musculoskeletal emergencies. Good. Hopefully I primed you guys enough by talking about our 3 musculoskeletal emergencies first. Great job, exactly. Our necrotizing infection or necrotizing fasciitis, septic arthritis, and septic tenosynovitis. And these are our 3 entities that are managed with emergent debridement. All right, this next case here is going to be serial images of a patient who had undergone hip replacement, and these are occurring over a period of 4 months. Give you a moment to just look at those. Then I just have a little close up here of the stem. Right, you can see that there's lucency around this stem, some periosteal reactioning. It's now actually poking out through the cortex here. All right, what is the process involving the femoral stem called in this case? All right, great. Looks like we're leaning towards D. So when we talk about our hardware in the hip, so subsidence is when the femoral component starts to sink into the hip or into the femur. And so if I look at these images, I can just see that this stem doesn't seem to be sinking into it. It's really just the tip that is starting to tilt and point out and then break through the cortex. And I only showed you some APs, but so I guess we couldn't be 100% sure that there's no dislocation, but there's not in this case. Didn't fool you guys there. And then creep actually involves the acetabular component. And so this is the case of loosening. So the acetabular component here looks fine. The femoral stem isn't sinking into the femur. It's just there's all this lucency surrounding the prosthesis, which is now progressively tilting towards the lateral cortex of the femoral diaphysis and then breaches the cortex. This patient got a CT scan, and we can kind of re-see those findings within the bone. So we see that there is lucency surrounding the femoral stem on the bone window, this thickened periosteum around the femoral diaphysis, and then actually some erosions posteriorly and then laterally. And then on the soft tissue windows, we can see those collections a little more clearly. So, rim enhancing collection surrounding that femoral stent emanating from the cortex, and then also emanating from the hip joint itself. So just collections around the hip joint and the prosthesis and loosening. So this was actually an infected prosthesis. So this was actually, this occurred shortly after the initial surgery. So this is a case of direct implantation from the hardware, or it can happen in the setting of trauma. Other modes of contamination we see commonly is going to be hematogenous. It's actually the most common cause of osteomyelitis in children, and then osteomyelitis in adults, and then contiguous spread, which is our most common route for the diabetic population. This is a tibial hardware just eroding itself through the skin on this patient here. All right, take a look at these images. This patient has a foot ulcer. All right, what is our next best step? Good. Looks like we're all leaning towards the contrast enhanced MRI. Now this, one more. Is Charcot arthropathy present? And this is important in whether deciding whether contrast is not required for our MRI exam. So looks like I didn't fool anybody here, or too many people. Good. I'm going to give another shout out to the SSR for another white paper on recommendations for contrast use in musculoskeletal imaging. They broke everything down into either contrast is not required, consider contrast, contrast is recommended, or contrast is required. And now when it comes to osteomyelitis, in general, non-contrast is sufficient. However, in our case, when we have a neuropathic joint with superimposed infection, contrast is actually recommended. It's also recommended for other complications of osteomyelitis, as well as further delineating the extent of soft tissue infection. So in this case, yes, I would agree with the majority of you that a contrast enhanced MRI is the most appropriate next step. So this is that patient's MRI, and we can see on the T1 weighted images that there is marrow replacement throughout the midfoot and tarsometatarsal joints. We can see on our contrast enhanced images and our T2 weighted sequences that there is a foot ulcer with sinus tracts intervening along the tarsometatarsal joints. And there is a lot of edema, a lot of hyperemia spanning the midfoot and the tarsometatarsal joints. So this happened to be a case of osteomyelitis in the setting of Charcot arthropathy. Yeah, and as I had said before, that in the diabetic population, osteomyelitis most commonly extends contiguously from an ulcer or postoperatively. But the problem with diabetics is that they get this neuropathic arthropathy, which is going to be marrow changes, marrow replacement, and edema in the absence of infection. And this can cloud our picture of whether or not there's osteomyelitis if there's suspected infection. And there are, the 6Ds of Charcot arthropathy, which is going to be disorganization, destruction, dislocation, debris, distension, and density change. And as we saw in our radiographs, we had disorganized, tarsometatarsal joints in midfoot. There was destruction, erosion spanning those joints. We had homeolateral dislocation of the tarsometatarsal joints. There was some osseous debris, distension of those joints, capsules. So we pretty much had all of the Ds of Charcot arthropathy. What can help us if we didn't give contrast is, ulcers, sinus tracts, abscesses can be a clue to diagnosing osteomyelitis if they didn't give contrast. But if they did give contrast, the patients with Charcot arthropathy demonstrate this ghost sign, in where when on the pre-contrast T1 images, the bones are indistinct and you can't see them as well. But after we give contrast in the setting of infections, those bones reappear. This is a case here we can see at the midfoot where I can really only make out a cuboid bone here. And then when we give contrast, the navicular comes back in. I got a cuneiform here. So these bones are reappearing. They're enhancing because they're infected. So we define osteomyelitis as infection within the medullary cavity and can spread hematogenously or contiguously. And those imaging hallmarks is going to be bone marrow edema, confluent marrow replacement, and then if they gave contrast, enhancement. Other findings we can see is going to be periosteal reaction, and then abscesses, whether they are in the bones or in the adjacent soft tissues, pointing us to the infection in the bone. Just like our previous case, this is just another picture of osteomyelitis. We've got edema at the midfoot. We've got an abscess here, marrow replacement and enhancement. Slam dunk for osteomyelitis on this one. There are a few mimickers of osteomyelitis. This is just another case of Charcot arthropathy, right? Marrow replacement, edema, but no infection. This here, we've got marked edema within the diaphysis of this tibia in a child. We see the open physes, adjacent soft tissue edema, marrow replacement, periosteal reaction. This happened to be a Ewing sarcoma. And then here we can see that there is distension of the first metatarsal phalangeal joint and the interphalangeal joint, where there are some osseous erosions, and then enhancement. This was a case of gout. So we mentioned that our crystalline arthropathies, such as gout, neuropathic arthropathy, can mimic infection, but so can inflammatory arthropathy, tissue necrosis, and trauma. So what do we do in this case? We see an ulcer here, lots of edema within the soft tissues, bone marrow edema, but then when I look on my T1, I don't really see any marrow replacement. So this is early osteomyelitis, or a high likelihood of osteomyelitis. So this is our discordant marrow signal. So what we're seeing is edema, but no T1 signal marrow replacement. And if this edema is adjacent to an ulcer, sinus tract, abscess, or other infected tissue, this has a high likelihood of progressing to osteomyelitis or early osteomyelitis. And these are still managed aggressively with wound care, antibiotics, IV, and then revascularization. And this is because, especially in the diabetic population, these patients do really poorly if this progresses to the point of needing amputation, because once you amputate, they start altering their biomechanics, get ulcers elsewhere, get more osteomyelitis, and just require more and more amputation. So treating these aggressively from the start really affects patient outcomes. And the reason that we are calling this early is because those fat metabolism changes, that marrow replacement is going to happen late, whereas the hyperemia and cellular infiltration or the T2 signal changes happen much earlier. And then, especially in diabetics, there's not great vascular supply. So those marrow changes, that turnover of the marrow, metabolizing the fat and becoming bacteria and being replaced with bacteria. We're not going to see that because of the poor vascular supply. Okay. This is a kid with severe leg pain. That middle image is our post-con, and then the bottom axial image is also a post-con. Good. Good. We're leaning towards this well-marginated rectangular area. This is our post-contrast enhanced image. And there's this area that was edematous on the axial sequences, but then does not enhance on our post-contrast enhanced sequences. So our sequestrum is our area of necrotic devitalized bone that serves as a nidus for infection. This is just another example of a smaller sequestrum. So we can see here on our T2 weighted image that there is this tiny fleck of edematous bone within the medullary cavity of this distal fibula. And then when we give contrast, it actually doesn't enhance. It's the same intensity as the normal bone of the, say the adjacent tibia. And it does have this surrounding granulation tissue. And then when I look on the axial images from caudal to cranial, we can see this new bone formation, periosteal reaction, and draining tract from that bony lesion into the soft tissues. This is that same kid. And we can see here that there is a fluid collection abutting the posterior aspect of that distal femur. And then this here is actually periosteum. This could also have a periosteal abscess or a subperiosteal abscess. So these are the more complicated cases of osteomyelitis. Starting off with that sequestrum, our devitalized necrotic bone that serves as a nidus for infection. And because it's necrotic and there's no vascular supply, it's protected from antibiotics. And then what we see imaging wise is going to be mineralization on CT, and then this T1 signal hypointense bone, and then relative lucency. Oop, 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 what just happened? And because it's necrotic, it's not going to enhance, as opposed to the periphery of granulation tissue surrounding that sequestrum. Our involucrum is going to be a capsule of new viable bone around the sequestrum, and that's going to have intergranulation tissue covered by a biofilm. So what you're going to see is this expansile coarse woven bone with expansile sclerosis edema surrounding the sequestrum. And these tend to drain through cloacas. That's what we saw in that distal fibula case, this opening in the bone through which the pus and debris can decompress. It can either communicate with the involucrum or sequestrum or be continuous with interosseous abscess, draining that pus out through the bone into the soft tissues. And as I mentioned before, because it's protected from the vascular supply and thus antibiotics, it has to be treated with debridement. So sequestrectomy, and then with or without the addition of antibiotic beads. We can also see interosseous abscesses. So that's that pus-filled cavity within the bone. On imaging, you're going to have T2 hyperintense fluid, and then it's going to be T1 hypointense or intermediate with the rim of enhancement. If we got diffusion-weighted imaging, it's going to show restricted diffusion. And then what we can see is this penumbra. So that's going to be this mildly T1 hyperintense rim of vascularized granulation tissue. This can kind of help us differentiate intraosseous abscesses from other entities, such as tumors, for instance. And then, as we saw in the kid with the sequestrum, he also had a subperiosteal abscess. So this is actually more common in pediatric patients because there's a much looser adherence of the periosteum to the bony cortex, and this septic material compresses the endosteal vessels and causes necrosis, and then they can fracture. It's important to recognize in the case of a subperiosteal abscess, yes, you can get beautiful MR images of these subperiosteal abscesses, but again, because these happen in pediatric patients, they have to be sedated often for MRI, but you can actually use ultrasound to look at subperiosteal abscesses. So you're going to have a decreased exam time, and you're not going to have to sedate the child for the examination. All right, let's take a look at these cases here. Give you a moment. Good. Most of you are saying benign. Couldn't fool you guys, even though it's a lecture on musculoskeletal infections. This was actually an osteoid osteoma, one of our mimics of the sequestrum. Other mimics are going to be an osteoblastoma, lymphoma, and Ewing sarcoma for those more complications of osteomyelitis and bone infections. All right, this is more of a review slide. Is there osteomyelitis? Okay, it looks like we're kind of not really split, but the majority of you are saying A, there is osteomyelitis, but it's not super, no one's really leaning towards one or the other. It's relatively equal. This actually is osteomyelitis. There's edema adjacent to infected tissue. So we call this osteomyelitis. These are some of the more soft tissue components of musculoskeletal infections. So that's going to be your ulcer here, extending through a sinus tract to the bone where we have osteomyelitis. And this also demonstrates some enhancement on our post-contrast enhanced sequences. So our ulcer is how our diabetics get infected usually. So that's a breach in the skin. So our skin acts as a normal barrier against bacteria. So once you have an ulcer, bacteria is able to get in and cause an infection. And then when it reaches the bone, that's when we get the osteomyelitis. Whereas the sinus tract is actually a channel draining pus, necrotic debris, either from abscess, osteomyelitis, usually extending through the ulcer to the subcutaneous tissues. And then when these sinus tracts and ulcers remain chronically, these can actually cause squamous cell carcinomas and malignant transformation. So those imaging features are pretty straightforward. Ulcer, skin disruption, with or without elevated margins. You're going to see that defect. It's going to be T2 hyperintense and have some peripheral enhancement. And our sinus tract is going to be more of a linear tract extending from the skin or ulcer deeper into the soft tissues. And that's going to have some tram tract peripheral enhancement. All right, let's take a look at these images. All right, what are some of your differentials for this? Yeah, this is a tricky one. I think it's always important to recognize when, even though the clinical suspicion may be infection, like what else could it be? So this happens to be a marginal ulcer. So this is that case of an ulcerating squamous cell carcinoma in the setting of chronically inflamed tissue. Because of it's chronically inflamed tissue, it's the most common malignancy in patients who have osteomyelitis, and it's very aggressive. So it's going to be debrided aggressively, and then it tends to recur locally often. Some other mimics, except for the marginal ulcer, which isn't as common. Trauma, sores, are vascular insufficiency and vasculitis, and scleroderma. You're right. This patient has cellulitis. Good. What about this one? T2, T1 pre, T1 post. Good. Both of those happen to be cases of cellulitis. So this is a superficial, non-necrotizing infection involving skin, subcutaneous fat, and superficial fascia, most commonly caused by strep, but staph in high risk or hospitalized patients. This is a clinical diagnosis. So erythema, warmth, swelling, tenderness, and then some systemic signs of infection. It tends to get imaged in the cases of suspected complications of cellulitis, such as abscesses or deeper infection into the bones or muscles. When we image it, ultrasound is going to show some increased echogenicity and cobblestoning within the subcutaneous tissues. When we look at it on CT, we're going to have fat stranding, skin thickening, and then on MRI, edema, infiltration with enhancement. Enhancement is our key here. And then if you got it, restricted diffusion, and that those appearances on MRI and CT tends to look more reticular. And as I mentioned before, we really only image it for complications. It's really a clinical diagnosis. So this is a case of bland edema or non-infected edema, so not cellulitis. We've got skin thickening, reticular edema here, but on our post-contrast enhanced sequence, there is no enhancement. This is a bland edema. So bland edema is one of our cellulitis mimics. That's going to be diffuse edema from excess fluid within the interstitial spaces. These patients are going to have no systemic signs of infection, and it's not going to enhance. Maybe we could think of some other cellulitis mimics, because even though we shouldn't really image this, because it's a clinical diagnosis, it gets imaged a lot. Good. Yeah. Yeah, people are leaning towards venous stasis. Like everyone's saying venous stasis. Exactly. First one, vascular insufficiency, venous stasis, DVT, mixed edema, lymphatic obstruction, drug rashes, trauma, such as the contusions, drug reactions, radiation change, and thyroid acropathy. I'm trying to go quickly through these because we're running out of time. Here we can see that there is infiltration of the normal Kager's fat, marrow replacement, and edema spanning the subtalar joint. And we can see that fluid within Kager's fat, again, edema spanning the subtalar joint, and this fluid and infiltration demonstrates some rim enhancement. So this is a soft tissue abscess and then adjacent osteomyelitis. So you've got for an abscess, it's a localized collection of necrotic tissue and pus, and it has that thick enhancing pseudocapsule. And then the patient's going to have some systemic signs of infection. CT is going to be hypoattenuating collection with room enhancement. Ultrasound is going to be hypoechoic with thick capsule internal debris. And MRI is going to be fluid intense, T2 high signal, and then T1 variable, depending on the degree of pus, blood, and proteinaceous debris within the fluid, and some rim enhancement. And again, diffusion is going to be high signal if it was obtained. I believe this is our last case. If we can take a look at these images of this woman who's got acute on chronic shoulder pain. She'd actually had an injection in the orthopedic surgery office of some steroid for this acute on chronic shoulder pain. All right. It's kind of a lot going on. Let's see what you guys can come up with for some of the findings that we see on the patient's MRI. And you can always give more than one answer. Good. Yeah. Exactly. There's this joint effusion, thickened synovium, lots of adjacent soft tissue edema. She happens to have a rotator cuff tear. So this angry fluid is extending through that full thickness rotator cuff tear into the subacromial or subdeltoid bursa, even into the acromioclavicular joint. And then we've got all of this intramuscular edema and then this fluid collection. This is just an example of pretty profound pyomyositis. That's going to be a bacterial muscular infection. It happened to have spread contiguously from the joint in this patient, but can also happen from direct implantation. What you're going to see is intramuscular and perifascial edema with a fluid collection, rim enhancement, and then diffuse enhancement within the adjacent muscles. And as you guys had mentioned, there was also bursitis. That's going to be infected bursal fluid. That's going to have similar imaging characteristics. T2 hyperintense fluid, T1 variable depending on the degree of blood and pus and proteinaceous debris, and then enhancement and thickening of that bursal lining with a lot of surrounding edema and enhancement. Again, kind of out of the, like with septic arthritis, it's going to be out of proportion to the degree of what you would expect for just a normal overuse bursitis. Some pyomyositis mimics, muscle strain, delayed onset muscular soreness, trauma, and denervation. This is just a case of a patient who ruptured their quadriceps tendon and has this feathery muscular edema, typical of muscle strain, so that feathery appearance. And then this is a patient who actually was doing eccentric bicep curls, and obviously targeted their, brachialis muscle instead. So that's our delayed onset muscle soreness. Quick summary. So we talked about our 3 musculoskeletal emergencies first, which is our necrotizing infection or fasciitis, septic tenosynovitis, and septic arthritis, which are managed surgically, and we never delay imaging to diagnose these things. Delay treatment to get imaging and diagnose these things. The hallmarks of osteomyelitis is going to be bone marrow edema and marrow replacement. And then if it's adjacent to infected tissue, edema is all that is necessary, that T2 signal hyperintensity to call early osteomyelitis. And then helpful clues for an abscess is going to be that penumbra, this hyperintense T1 signal rim, to help differentiate it from tumors. And that there's a huge differential for cellulitis. So just make sure there's a high clinical suspicion. And then if they gave contrast that, it enhances. Sorry, I went over, guys. If you have any questions, I think Bill is going to help me with that.
Yes. So we have some questions from the audience. Great talk, by the way. Fantastic. I think everything was really, really clear. A question here is, would you add diffusion-weighted imaging to your protocol? Especially they mentioned in the case with intramuscular fluid. How would you differentiate it from necrotizing fasciitis?
I wouldn't add diffusion weighted imaging to our protocols. I think that in the cases of muscular infection, your fluid weighted sequences, your contrast enhanced sequences are going to be enough to help you. And I feel like diffusion weighted imaging might cloud the picture a little bit because diffusion, just like enhancement, is non-specific. It's just going to show hypercellularity. So tumors are going to have, high signal on diffusion weighted imaging. So I wouldn't personally add it. It's just, that's what the literature says. If you got it, maybe it was done on a abdominal, an abdomen and pelvis MRI, and there's a lesion and they happen to have gotten diffusion weighted imaging, and that's why you have it.
Yeah, Dr. Avnish Chabra from Texas did research on DWI in infection. So if anybody wants to look more up, look up Dr. Chabra's work. The other question is, are there any good ways to differentiate infected joint from particle disease?
Yeah, so the particle disease is going to happen in particle disease is going to happen in the setting of a hip replace or a joint replacement, usually hip. And that's the metal on metal. And so when you aspirate the joint, there are specific tests in the aspirate that you can obtain. I think the brand name is Synovasure, will tell you if there is a periprosthetic infection. And it's not going to have your white count cutoff within that fluid is going to be lower. And then imaging wise, particle disease is going to look very similar to infection, an infected joint. Yeah.
Yeah, I mean, your images were awesome. Your talk is great. And I like to think of infection as being like looking angry. You showed a few cases of like rheumatoid arthritis, and rheumatoid arthritis, the effusion starts slowly and builds up, expands the capsule and stuff. Infection is like, I talk about a fat guy in a little suit. I mean, it bursts out. It has periarticular edema around septic arthritis, around osteomyelitis, a lot of edema. So when you see something looks really angry, think about infection. With particle disease, it's more slow growing and more expansile, usually lower signal on T2. So there are ways to differentiate. Sometimes you really can't, you need to aspirate it. But my last question for you for the last minute here, Ali, is what's the role of nuclear medicine in today's imaging of infection?
We tend to use nuclear medicine rarely at Brown, not super often at Jefferson. I think can be very helpful in cases of chronic osteomyelitis, more so chronic infections. So when you're really unsure if this is, active infected tissue, and the T1, the T2, and the enhancement that you're seeing on your more advanced, MR imaging isn't giving you a clear answer. Yeah, and that's going to be usually your tagged white cell scan. Was what you're going to get in the setting of osteomyelitis, but it's not used often. Maybe things have changed at Jefferson since I left, but we didn't really use it that often.
I agree. MRI has really taken over for that purpose. If you can't get an MRI for various reasons, it can still be useful. Tagged white cells can be useful. The limitation, obviously, if they have vascular issues, then it's hard to get those little cells over there, the tracer. So I think we're out of time. Ali, Dr. Sax, fantastic talk, and really appreciate you coming on board here today.
Thank you for having me.
All right, and that wraps up our session here. Thank you all for coming.